Hi, this is Michelle Knighton from ICSA Labs. We're going to go ahead and get started now. If you hear some beeps, those are some participants joining. I am the Health IT Test Lab Manager at ICSA Labs, and today I'll be joined by my colleagues Kevin Brown and Amit Trivedi to provide an overview of the 2015 edition final rule. Kevin is our Health IT Security Manager, and Amit is the Program Manager for all of our healthcare programs, and we thank you for joining us today. Okay, I have a note that someone can't hear me. Can someone just confirm that you can hear me? Okay, great. Thank you. Appreciate that. Okay, so to continue, just a few housekeeping items. First, if you haven't, please mute yourself. I do have the mute feature on, but just in case, it's just always a good thing to do. We are recording this session. We're going to post it online within the coming weeks, and we will notify you once that's been done in case you have some team members who would like to listen to it. If you have any questions as we walk through the seminar, go ahead and use the chat WebEx. So if you put your cursor at the top of the screen, you should see a chat icon. It may default to sending the message to everyone. If it does, just change that to my name. Again, I'm Michelle Knighton. Today we're going to be focusing on the 2015 edition final rule. So there are a number of items that we want to bring to your attention, including the significant changes in criteria that were tested in the 2014 edition program, as well as new standards. Kevin's going to walk you through how privacy and security is going to be handled in the new program, while Amit is going to discuss new surveillance and transparency requirements. And then at the end, we're going to wrap up by discussing program timelines as well as anticipated launch dates. First, we're going to go over some new concepts. So Health IT module replaces the term EHR technology. This is intended to provide more flexibility, as some going through the ONC certification program are going to be doing that for purposes other than meaningful use. The ONC also revised the definition of the base EHR, and we will go through that in just a minute. They've also used the term common clinical data set, and this is going to replace the common meaningful use data set that you saw in the 2014 program. They've also removed the complete EHR concept. So complete EHR certifications are not going to be issued any longer, beginning with the 2015 edition program. Now keep in mind that doesn't affect the 2014 edition program or any complete EHR certifications that have already been issued. As we talked about, EHR module was renamed, so now that's going to be referred to as the Health IT module, so that will be the certification designation as Health IT module. And that's to better reflect the non-EHR products that might achieve ONC certification like HIS and HIEs. They've removed the security requirements from the base EHR definition, and instead they're going to be dependent upon testing other criteria. So what that means is, for example, if you were testing the demographics criterion, you must also test criteria D1 through 7. And that's something that we'll get into a little more detail once Kevin is talking to you about those privacy and security requirements. Additionally, the requirement to test G1 and G2, and that's the automated numerator recording and the automated measure calculation criteria. However, CMS still includes this as a requirement in the certified EHR technology definition. So the purpose of doing this is to allow products that are achieving certifications for purposes other than meaningful use greater flexibility. However, keep in mind that if you or your clients are going for meaningful use incentives, you will be required to test G1 or G2 for all percentage-based measures, just like we saw in the 2014 program. Next, let's talk about the base EHR definition. So this is from Table 7 of the 2015 edition final rule. Remember, the base EHR is not a certification status. However, as you know, providers have to have certified products that combined meet this definition, as this is one of the founding requirements to meet CMS's certified EHR technology definition. So a couple of Important things here, you'll see that smoking status and implantable device list have been added. So smoking status is an existing criterion, whereas implantable device is a new criterion. And the ONC has also added 3 criteria related to API. Those are G7, G8, and G9. So those 3 application access criteria have been added. And there's also included some optionality into the definition. So, for example, if you look at CPOE, you can now see that the system only needs to be tested to A1, A2, or A3 rather than all 3. And so those are the 3 CPOE criteria, 1 for each order type, medication, labs, imaging. Also for direct, you can certify to criteria H1 or H2. And those are related to the direct. Here is the new and improved Common MU dataset, now called the Common Clinical Dataset. So first let's talk about sex. Sex now requires that HL7V3 be used in combination with a null flavor value, and those values should have attributes of male, female, or unknown. And this coding that ONC has stated is intended to represent birth sex only. For race and ethnicity, in addition to the OMB standard, we now see that they are requiring the CDC's race and ethnicity standard. It has over 900 concepts. That's required to record each one of the patient's races and ethnicities, and those then must be aggregated to the categories in the OMB standard for race and ethnicity. They've again changed the standard for preferred language. Instead of ISO, they're requiring RFC 5646. This is a standard that's compatible with CCDA Release 2.1, as well as allowing other preferred language standards to be mapped to it, including those ISO standards that were required in the 2014 edition program. For problems and procedures, so numbers 8 and 14 on the list here, the September 2015 U.S. edition of SNOMED is required. And you'll note that for a system that's primarily developed for a dental office, that CDT, so the dental systems, can continue to be used for procedures. Similarly, we see updated standards for LOINC. The LOINC standard has been updated from 2.4 to 2.5.2, and vital signs now have some required standards. Again, they're using the new LOINC standard, and they're also requiring that you use the Unified Code of Units of Measurement standard. Immunizations, number 16, those were added, and they require HL7 CVX dataset, and in these we'll talk about the details related to those a little later. For 17 unique device identifiers, those items are a new addition, and they do require a CCDA. And then for the care plan fields, including goals and instructions, those were split into the last 3 categories that you see, so 18, 19, and 18 and 19 on the list, 18, 19, and 20 on the list. These are the certification core categories. There are 60 criteria altogether. Keep in mind that there are no longer any optional criteria. Complete EHR is gone as a designation, so therefore no criteria are optional. There are, however, some criteria that have some optionality within them, and we'll talk about that in a little bit later. For those of you who want to know about the definitions of how the ONC categorizes whether a criterion is unchanged, revised, or new, we developed this slide for you. They've also changed the definition slightly for some of these. So there are 16 unchanged criteria. These are the only criteria that are eligible for GAP certification, and it means that the capability was in a previous certification program and that the capabilities are the same or less of the same. There are 25 revised criteria, and that's the deep dive that we're going to do today. Those are changed or additional capabilities or a new capability that wasn't previously certified. There are also 19 brand new criteria, and so these are capabilities that have never been in a previous certification program. Keep in mind that there is one criterion that is both revised and unchanged, and it is criterion F2, syndromic surveillance. It is revised for the inpatient domain, but unchanged and gap eligible for the ambulatory domain. So now that we've talked about some of the base concepts in the program, let's turn our attention to those notable changes that were made to the criteria falling into that revised category. First up is demographics. So again, you're going to see a lot of information here that we already covered on the common clinical data set slide. Again, sex has to be recorded using HL7B3 and MIL flavor. Race and ethnicity is using the CDC code system as well as OMB. Preferred languages no longer allowing ISO. Date of death is a brand new element for the inpatient domain, and that's in addition to the current preliminary cause of death data element for inpatient. Also brand new for both domains is the sexual orientation and gender identity element. For clinical decision support criterion A9, we simply see that they updated some standards here, both the info button standard and the 2 implementation guides that are used. And they removed the terms automatically and trigger. And they say that they've done that because they really want to make sure the intent is to encompass all types of CDS interventions. And they don't want to be prescriptive on how those interventions have been deployed in the system. A12 family health history, now requiring the latest version of SNOMED CT, the September 2015 release. And also, although I don't have it on the slide here, criterion A6 problem list, it's also using this updated standard of SNOMED. Patient education, the most notable thing here is that other EHR function is no longer allowed. So you have to use the info button standard. It doesn't mean that you can't have additional capability in your system. It's simply that for certification testing, we're going to focus on the info button. You can now have a new optional requirement. You can search for patient education materials using both the info button and the patient's preferred language. So if the patient's preferred language was Russian, you could combine that with the search of info button and bring up only Russian patient education materials. Again, we're seeing that the newer info button standard and implementation guides have been adopted. They've also removed the labs requirement, and that's because the info button can't fully support this level of data specificity. For criterion D3, this is where we're going to see a lot of changes. So historically, you've been tested on the new prescription transaction type. Now they've added a number of other transactions, including changes, refills, cancels, bill status, and medication history, and they've specified that all of these are required to be bidirectional transactions. The system must also be able to receive and transmit the reason for the prescription using the diagnosis element in the DRU segment. And optionally, you could send that reason for the prescription using a different standard, the structured and codified SIG format. Again, not required, but it is something that you can choose to certify to. They're also only allowing metric to be used for oral liquid medication, so CC units aren't going to be allowed any longer. And then finally, the system has to be capable of inserting leading zeros before the decimal point if the amount is less than 1, and eliminate trailing zeros after a decimal point. So those are some big changes for e-prescribing. Next is our data export criterion. That's similar to the 2014 data portability criterion. They've updated the CCDA release that needs to be used, and they've also specified a number of other requirements. First is that a system has to be able to export a summary for either a specific patient or a batch export of a set of summaries for as many patients as the user selects. They have specified that that new common clinical data set is the minimum data, in addition to some other data elements like encounter diagnosis, discharge instructions for inpatient, things like that. And those will all be specified in the test procedure. Additionally, the user must be able to enter a start and end date range. And so what they've clarified on that is that the user has to be able to create summaries in real time. They have to be able to do them on a relative date and time. So all the summaries from last month, I want them on the 15th of this month. And then based on a specific date and time. So I want all the summaries from yesterday to be provided to me today. The user must also be able to configure and set the storage location where the summaries will be saved, and the system must be able to limit functionality to a specific type of user. Now, keep in mind, we're going to see this in a few other criteria, that this does not mean you can limit it to a user on the developer end. It must be a user on the client side. So, for example, maybe only the physician can do this, or maybe only an admin user. So let's talk about clinical quality measures. Updated implementation guide release 3 for the QRDA Cat 1 messages. And again, you see this requirement that you cannot rely on the developer for these actions. So users must be capable of exporting those Cat 1 files themselves on demand. We see that reiterated for C2, which is the import and capture criterion. So the user has to be able to import CQM data using QRDA Category 1 Release 3, again, on demand. And then the ONC has also allowed an auto deduplication requirement. However, they have chosen not to prescribe how that will be demonstrated or what systems must do with the imported data after it's been selected for deduplication. One thing to keep in mind here for C2 is that in the 2014 program, if a system tested to all 3 of the clinical quality measure criteria, for C2 they were allowed to manually enter CQM data. That has been removed. Your system must now be able to import QRDA Category 1 files at the user level, not at the developer level. Okay. For C3 CQM's report, again, the newest version of the Category 1 and Category 3 specs have been adopted. And remember, C3 requires Cat 1 and Cat 3. And then there's another optional item here. You can comply with CMS's form and manner requirements that are defined in their QRDA implementation guide. For F1, this clarifies some of the requirements we talked about earlier in the Common Clinical Data Set. So they've adopted an updated implementation guide as well as the addendum. And then they said that when you're reporting immunizations at the time of administration and the actual product is known, your system must be able to send the NDC code. So for administered vaccines, you have to use NDC. For the historical vaccines, CVX code set should be sent. So if you're sending historical vaccines and the actual NDC code isn't available, you're going to use the CVX codes, and you're going to use the August 17th version of those. Finally, they've stated that immunization history and forecast from the immunization registry must be provided. So for this one, the user has to be able to request, access, and display the patient's immunization history as well as the forecast from an immunization registry. And this is to allow the user to be able to both see and compare that forecast that's being provided from the immunization registry versus what's in the certified health IT product. F2, transmission to public health agencies. This is syndromic surveillance. Remember, this is a criterion that's both revised and unchanged. So it's revised for inpatient, gap eligible for ambulatory. Here you're just going to be using the updated FIN messaging guide as well as the addendum. And they did specify that that implementation guide has some instructions that talk about the frequency of submitting the data. However, that is outside the scope of certification, so it won't be part of certification testing. Finally, F4, transmission to cancer registries. Again, just some updated specs here. The R2 implementation guide release 1.1, and then updated versions of SNOMED and LOINC. And with that, I'd like to go ahead and turn it over to my colleague, Kevin Brown.
Hi, welcome everyone. So some other changes have to do with transitions of care. They are now going to require the ability to create and parse both version 1.1 and 2.1 of the CCDA standard. This has a lot to do with backwards compatibility. They're also going to require the ability to detect errors in the CCDA. And probably one of the more significant changes, they are going to require enhancements to the navigation CCDA documents. Apparently one of the complaints has been with the length of the documents. So for navigation purposes in 2014, you could use a style sheet that had essentially hyperlinks to navigate the document. That is no longer adequate. They're requiring some additional features such as reordering of the sections, hiding certain sections, setting the initial quantity of sections to be displayed, that sort of information. For D8 integrity, the significant change there is SHA-1 is no longer supported. Everybody must now support one of the SHA-2 standards at a minimum. So therefore, integrity will no longer be gap eligible. Everyone will need to redemonstrate that one. For H1 and H2, which are carryovers from 2014 Release 2, they're now upgrading to the applicability statement for Secure Health Transport version 1.2, so that's an upgrade to the direct requirements. In the past, you could send unwrapped only or unwrapped and wrapped messages via direct. You're required to do wrapped only now, and sending and receiving of MDNs is now explicitly required. Next slide, please. There are a number of changes to E1 view, download, transmit to third party. Similar to the clinical summaries, they want patients to have the ability to select what data and by what date range, which information they want to view, download, or transmit, giving a lot more flexibility to patients so that they can be sure to access the specific data they want to see. Also, the patient record now must include also diagnostic imaging and lab results on the portal. One of the significant changes to the audit log for E1 is to include the recipient addressee. They, at this time, are not requiring confirmation that the message was received, but the recipient address must be reported in the audit log. They've also made a really big change in the transmit portion. So here, before direct was required, the ability to transmit. Apparently, due to some issues with the availability of direct in the real world, what they've decided to do was, at a patient's discretion, have the ability to send a standard email to any recipient that they want, but also the Health IT module must support an encrypted form of electronic transmission, such as direct. They're still encouraging direct. They want people to move that direction, but it is no longer required. This will be covered under the D9 criterion, trusted connection, which is one of the new criteria. Now, when encrypting, you can either encrypt the transmission, essentially the transport layer, or you can encrypt the payload itself. Both of those are acceptable. And they've done things like remove the authentication requirement out of E1, but when you're certifying E1, you will have to meet the authentication requirement for D1, which is what we'll talk about here briefly with the security framework. So you'll still have to do authentication and auto log off and some additional features there. But those are going to be incorporated through the privacy and security certification framework that we'll talk about. And then with secure messaging, similar to the view, download, transmit, you can use message level or transport level encryption. And some of the other privacy and security criteria apply, again, authentication, auto log off, and so on. Next slide, please. Safety enhanced design has undergone several changes. There are 12 total applicable criteria. Now, some of the criteria were removed because the criteria are no longer applicable to the 2015 edition, but other criteria have been added. And so if you're going to be testing against certain criteria, you'll have to do safety enhanced design along with it. They now have established a minimum number of participants. The number is 10. Previously, there was no minimum number required. The intent will still be for each organization to demonstrate that they have a sufficient cross-representation of the intended user base, but there is a minimum number of participants now of 10. Going forward, the ACBs will be obtaining quarterly records of any and all adaptations and updates that affect safety enhanced design. So that's going to be an ongoing surveillance type of activity. And they are going to permit submission of alternative acceptable user satisfaction measures. It still remains to be seen exactly what that's going to entail. But they are going to allow some alternatives from using like the NIST 7742 report, but the expectation will be that the same type of data will be captured. With Quality Management System G4, probably the biggest change there is that previously in 2014, You could state that we don't use a QMS. It was a full disclosure requirement, so just simply saying you didn't use a QMS was still enough to meet that requirement. That is no longer permitted. You must use a QMS going forward. The identified QMS system you use must be one that's either established by the federal government or another standards developing organization, such as ISO, for example. Most everyone's probably familiar with them. Or you can map to one or more of the QMS systems that are established by the federal government or SDO. So either you could either use 9001 or you could show how you're mapped to 9001, for example, ISO 9001. Now, it's also important to remember that for this one, there's going to be some, well, let me back up. So agile software development practices are permitted. The thing that I was just going to say is the focus and the intent of the provision is identification of the QMS, not compliance. So if you are, say, ISO 9001 certified, you would not have to provide an ISO certification number. You would just have to identify that ISO 9001 was the quality management system you were using. Next slide, please. All right, so next I'm going to talk about the Privacy and Security Certification Framework, which is what ONC is calling it. Next slide, please. So as Michelle mentioned earlier, the privacy and security criteria are no longer included in the base EHR definition. Instead, what they're doing is, for all of the other criteria that you're certified against, that will determine the applicable privacy and security criteria. So the goal is to ensure that all the health IT modules that are presented for certification possess the relevant privacy and security capabilities. So for example, all relevant health IT modules must support authentication, not just one component provided, used by the provider. So in the past, you could have authentication into the EHR, but if you were using, say, third-party software through a website, that authentication didn't necessarily apply to that external website. Now, for every component that you use, certified to a specific criterion, there will be applicable privacy and security criteria. So there are two approaches to demonstrate compliance. The first one is through technical demonstration, which is essentially what you do now for certification. Approach 2 has to do with the system documentation. You'll basically be attesting to how you use an external service in order to meet the requirement. I'll talk more about that in a moment. Now, what this does is, it's part of the intent is to take the burden off the providers so they no longer have to ensure they possess technology certified to all the privacy and security criteria, but rather that when they acquire health IT software, that whatever they acquire already meets the relevant privacy and security criteria. Next slide, please. So here's a list of the criteria themselves. You will see D9 and D10, trusted connection and auditing actions on health information. Those are two new criteria. The rest are essentially carryovers, although there are some changes to them. Next slide, please. So here's how the framework itself works. So anybody certifying any of the A criteria will need to comply with D1 through D7, all of those privacy and security criteria. Whereas if you're testing any of the B criteria, you would need to do D1, 2, 3, 5, 6, 7, and 8. And as you go down the list, you'll see that there are different requirements. Now, they're all logically grouped by their section, with the exception of for E1 and then E2 and E3, they're subdivided. E1 requires D7, which I believe is end-user device encryption. E2 and E3 do not. And then, again, approach 2, so for each of the applicable criteria, you can submit system documentation detailing how you can integrate with external services to meet this criterion. Next slide, please. Now, there are a few specific criteria that are exempt from the new framework. First would be the privacy and security criteria themselves. There's no interdependency between them. So if you're testing D1, that doesn't mean that you have to do D2 or vice versa. And then criteria G1 through G6, ONC has determined that these criteria don't impact privacy or security for end users. Therefore, they are exempt from the framework. All other criteria are part of the framework and do have interdependency with its privacy and security criteria. Now, just to expand upon approach 2 a little bit, this approach will apply when different HIT modules share a common security infrastructure. So the idea is that the developer would only need to certify the infrastructure once, not multiple times. So, for example, you wouldn't have to demonstrate authentication, multiple times for different criteria. You'd just be able to submit documentation stating how you integrate with an external services, maybe like a domain controller through Active Directory services in a Windows domain environment. They have specifically stated that developers will not be able to attest that any of the privacy and security criteria are inapplicable or infeasible. The expectation is if you're testing against one of the relevant criteria, you must do the relevant privacy and security criteria that are associated with it. E1 and E2 must be tested separately to D9. So despite the fact that, what I just said about certifying the infrastructure only once, the trusted connection portion of E1 and E2 must be tested and demonstrated separately. So you'll need to show a trusted connection for view, download, transmit, and a trusted connection for secure messaging. One of the things that doesn't directly affect the certification criteria per se, but ONC made a point of stating in the final rule is that how the actual implementation of these capabilities is done is really outside the scope of certification, but they're still going to be guided by applicable federal and state privacy and security laws. So as you're implementing these features and functionality, just be aware that there may be additional requirements that you have to adhere to beyond the final rule. Next slide, please. And at this point, I'd like to go ahead and turn over the presentation to my colleague, Amit Trivedi.
Thank you, Kevin. And so for the next few slides, I'm going to cover a couple items that have to do not so much with testing, but maintaining your ONC Health IT certification and some new attestation type requirements as well that relate to transparency. So next slide, please. All right, so let's start with some of the new requirements that are related to post-certification and surveillance. And so one of the big changes is the reporting of surveillance results. Currently, ACBs are required to create an annual report to ONC that details their surveillance activities. Now, ACBs will be required to report to ONC quarterly on any surveillance issues and corrective action plans that are submitted. I did just reference the corrective action plan, and so that's also a new requirement from the 2015 edition rule. So any nonconformities that are identified based on surveillance activities will require developers to submit a corrective action plan to their ACB within 30 days of being notified. Part of that includes reporting information about the corrective action plan to the ONC View Open Data Chapel. In the final rule, there is a comment in there that ACBs should ensure that the contents of the surveillance results submitted to ONC do not include any information identify the user or location that was participating in or subject to the surveillance. One other additional requirement that's related to surveillance and the surveillance activities for the certification body is that the final rule has now mandated that as a condition of certification, that health IT developers must furnish upon request accurate and complete customer lists, user lists, and other information necessary to enable ACB surveillance activities. And so one of the things I'll be talking about next is in-the-field surveillance. And so this is a shift from testing not so much the product, as most of you are familiar to, but going and looking at how the product is implemented on site and ensuring that the product continues to function as intended. So there's a number of functions of surveillance, whether it's doing user surveys or getting to the point where we're actually in the field and testing testing products on site, where the ACB will need to know things like customer lists, user lists, and we'll be requesting that. Some of you have already been participating in our surveillance and have been tabbed in previous years to complete surveys or submit customer information so that we could send out survey information, but this requirement is being ratcheted up a bit. So the requirements for random surveillance are effective at the new year. The others go into effect when the final rule goes into effect, which would be 90 days from publication. Next slide, please. And so one of the big shifts in surveillance and testing is the distinction between reactive surveillance and the new requirements for randomized surveillance. So reactive surveillance is probably something that folks are used to. That means surveillance activities are triggered based on complaints, based on repeated inheritance requests, product updates, and then any other information that the certification body may receive about potential nonconformities, including being nonconformant to the transparency and disclosure requirements that have been added to the 2015 edition rule. And so the other part to that is the randomized surveillance. And so this is a bigger requirement going forward. Randomized surveillance will be based on a random sampling of all products that are issued a certification, so 2014 edition and 2015 edition. ACBs are permitted in the final rule to implement a weighting and different sampling considerations when we do select the products for random surveillance. And so basically, we're asked to ensure that every product that's been selected and every provider location at which the product is in use has a chance of being randomly selected for in-the-field surveillance. And so it turns out that at least 2% of all products that are issued a certification must have random surveillance. And then for the products that are selected, we'll select a random sample of one or more locations that that product is installed at to do the actual in-the-field testing. And so this is a newer requirement. We're working with ONC to get additional guidance around that. ONC also has subgroups, work groups that are working on piloting some of these activities and providing additional information that will help ONC with the guidance that they're about to publish on that. So next slide, please. And so, again, on in-the-field surveillance, ACBs are required to initiate in-the-field surveillance as necessary. And then the idea there is to assess certified technologies to ensure that they're compliant when implemented and used in a production environment. And so then when we do in-the-field surveillance, one of the requirements is that the assessment of the capabilities must be based on the use of production data. Most of you are used to testing with test data, and that's how we typically do most of the testing in this program. However, for the in-the-field surveillance, they have specifically requested that we test using production data, not test data, unless ONC grants an exemption. And so whether through randomized surveillance or any of the other reactive surveillance activities, if we confirm a nonconformity, basically you have 30 days once notified to submit a corrective action plan. The final rule goes into details in terms of what the corrective action plan must include, but it's, typically there's about 5 or 6 items, identify the nonconformities, how widespread the nonconformities are, how the developer will address the deficiencies, how the developer will ensure that all affected customers are alerted to the nonconformities and what's the remediation plan, the time frame that the corrective action plan will be completed, and attestation at the end that from the developer that it's completed all of the elements of the corrective action plan. And so again, some of that information will also be transmitted to ONC as part of the Open Data Chapel. Next slide, please. And finally, there's some additional transparency and disclosure requirements. For those of you who tested in the 2014 edition, you're probably used to the attestation that we look for around additional costs. One of the changes there is, now ONC is required that all certified health IT developers must conspicuously disclose in plain language on their website or in all marketing materials, communication statements, et cetera, anything related to certified health IT, additional types of costs, and now these are types of costs, not actual dollar amounts, that users may incur to implement or use health IT, and the change here is for any purpose within the scope of the certification. Previously, it was limited in scope to just those functions that were required to achieve meaningful use objectives. Also, there's going to be new disclosure requirements around any limitations, including contractual, technical, or other limitations that are likely to limit a user's ability to implement or use health IT for any purpose within the scope of the certification. And again, this is a new requirement. We're going to be looking to ONC for additional guidance. And when we publish our 2015 edition materials, we'll try to also provide examples of these things for folks so they get an idea of what you're looking for in this type of attestation. And so as part of the transparency and disclosure requirements, health IT developers are required to provide a hyperlink for all disclosures, and that hyperlink will be published on the chapel. We've already been suggesting this to folks who go through and develop press releases for their certified products. Anyone who's gone through that process with us knows that we review the press releases to ensure that all the required elements that ONC asks for are present on the press release. And typically, all those required elements need to be on any other marketing material. And it turns out to be a pretty lengthy list of information that's not always feasible to put on adverts or smaller advertisements or other promotional things. So we've always suggested that folks have a page on their website that they can link to that has all of the official required certification information, like the transparency and disclosure requirements, the CQMs that you're certified to, et cetera. And that way you can always refer to that link instead of having it published on every piece of information. In addition to that hyperlink, vendors or health IT developers will also be asked to make a transparency attestation indicating whether or not you will provide additional types of cost information to other persons and organizations upon request. So again, this is another attestation item, whether you will or won't provide this additional type of cost information to folks upon request. Next slide, please. And so that was, and please on to the next slide as well. So this kind of wraps up our initial overview into the 2015 edition. As Michelle mentioned, this wasn't going to be the deep dive into the individual criteria. We're hoping that this will be one of a series of webinars where we'll increasingly provide more detailed information. And so looking at our timeline and what we have on deck for the 2015 edition test procedures, right now we're in the public comment period for all the draft test procedures, which are currently available on the ONC's website, and that public comment period will run until the end of the month. The finalized test procedures, we should see them approved by mid to late December. Comments on test procedures, the draft procedures, they can be submitted online. You can find that on ONC's website, while comments to an additional element of the 2015 edition, which is the certification companion guides, which are additional documents that provide more background and additional context for the test procedures. Any comments to those certification companion guides should be sent to the ONC directly in the email shown on the slide. Next slide, please. And then the effective date of the final rule is 90 days after publication, and so that would put us at January 6, 2016. We anticipate that 2014 edition testing will continue through fiscal year 2017. There's no expiration date that's been set at this time, and that's officially set by ONC. The 2015 edition certification testing, we would anticipate it will begin no later than the end of March. It may begin sooner than that, and it depends on a few different items, like the accreditation scope expansions being granted for the test labs and the cert bodies, the test tools being all finalized and released, and that all of the test lab and certification body staff training has been completed by ONC. So they'd like us to, of course, get started as soon as possible, but likely February or March is when you'll see the testing start. ONC has indicated that they'd like the testing to begin no later than the end of March. Next slide, please. And then, so as I mentioned earlier, this is going to be the first in a series of webinars. We're going to have additional 2015 edition webinars. We're hoping to look at this Tuesday time slot, probably a similar time. It seemed to work well for people, 2 p.m. Eastern. We'll do a deep dive of the 170.315 test methods, probably breaking them up into 2 sections. We'll review the additional attestation requirements and probably pass on any new and updated information we have on surveillance. As we know, there'll be new policy guidance coming out for that as well. So you can monitor meaningful use and ONC Health IT certification announcements from ICSA Labs by signing up on our e-newsletter. You can sign up using the link on the slide, which we will send out to folks who've signed up for this webinar. You can also find that on our website. Next slide, please. And then for more information, you can find these additional resources. You can go to ONC's site and read the 2015 edition final rule. You can submit comments on the 2015 edition draft test procedures. And then you can also review the new draft certification companion guides and then submit comments directly to ONC over email on those. Next slide, please. And with that, we have a few minutes left, and hopefully we can help answer any questions folks might have. And again, we'll be going into a deeper dive on the test procedures once they're actually finalized. That way folks are, we're able to answer questions on final as opposed to changing test methods. And so if you have any questions, maybe the easiest might be to type them in the chat window, and we can field them from there. But thank you all for your time, and we appreciate you being able to join today.
Great. Thanks, Amit. We do have a couple of questions. First, just to address what Amit said, we will be sending out the slide deck and the recording to the webinar to everyone. And the first question is G3 required for GAP certification items? So those criteria that haven't changed, is G3 still required for them? And so, Kevin, I'll turn that one over to you.
Yes, G3 itself is not GAP eligible. So even if you were doing a GAP eligible certification for one of the applicable criteria, you would still need to redo safety enhanced design. Part of the reason for that would have to do with the minimum number of participants required. So you would need to conduct your usability testing again. If the version information and other functionality hadn't changed, and let's say you had 5 participants in your initial evaluation, it might be possible to just add 5 additional and actually combine the results of the 2. but there's going to need to be some discussion about exactly what all information is required to verify that sort of, like I said, the version hasn't changed and any other applicable functionality hasn't changed. But officially, G3 is not GAP eligible.
Great, thank you. And then the next question is, do we know when the new test script formatted by ICSA Labs will be available? So in answer to that, that test script will be available when we are ready to launch the program. So just as a reminder, that will be at the latest by March 31st. However, we anticipate being ready before then. We are also looking at providing our prep materials, including the test script, sample messages, and things like that, available for a smaller fee before you actually sign up for certification testing. And we'll be sending out more information about that as we finalize it. Okay, so the next question is about B1. So Kevin, I'll direct this one to you. Which sections of the summary must be parsed?
The answer to that would be all of them. So there's information in the final rule saying that for end users, the sender is permitted to remove data that's deemed not clinically relevant before sending. But on the recipient side, the recipient must be able to receive, display all of the different sections, and that includes being subject to the hiding different sections, reordering sections. So even the sections that aren't required for incorporate must be displayed and subject to the section parsing requirements.
Great. Thank you, Kevin. And then I also just want to mention the beeps that you're hearing. We did have someone look into that, and on our future webinars, that will go away. So I apologize that you're hearing all those beeps. I know it's annoying, and it certainly makes it difficult for you to hear things. So just know in the future webinars, that will go away. Okay, so next question. So there's a question about, will there be 2016 edition criteria, and when do you expect the 2017 edition final rule to be published? So I do not anticipate that there will be a 2016 edition criteria. We do anticipate there will be a 2017 edition criteria, and usually I would be looking for that probably in 2017. So this is 2015. The final rule came out for the 2015 edition criteria this year, and so I would anticipate within 2 years another one would be published. However, that timeline is completely up to the federal government, and so we'll be looking at them to assist in providing those timeframes. Okay, and then another question, is it true that the 2015 edition certification must be attained by 2018? And the answer to that is yes, and that is just something that's defined by CMS. So they have stated that by 2018, providers should be using the 2015 edition certified criteria. So when you saw that slide that talked about 2015 edition testing through 2017, that's the reason for that. And if you want to reach out to me privately, I can send you the sections of the CMS final rule that talk about that, because there are a lot of different nuances depending on what stage of meaningful use the provider is in. Okay, so just looking through some of the other questions. There is a question about, is the cancer case registry now required for ambulatory EHRs? So first, the disclosure, remember there are no required criteria other than some of the like G3, G4, some criteria that have dependencies. And I think what you're talking about is the CMS side of things. So there's no requirement that cancer case registry be certified from a certification perspective. But there are some nuances about the public health reporting. And again, I don't want to get into all the nuances, and it's a bit out of our scope for certification purposes. But I can direct you to the portions of the CMS final rules that talk about all of those nuances and how someone might be able to meet the public health reporting objective related to cancer case registry and some of the other registries as well. Kevin, there's a question about G4 QMS. The question is, would mapping to the FDA's 21 CFR 820 requirements for medical device manufacturers satisfy the new requirements? And that might be something we need to get back to you on, but Kevin, I'll direct that to you.
No, you just pretty much gave my answer. As far as specific requirements, if they're not specifically called out in the final rule, and there are some QMS systems, I believe, that are specifically identified, we would have to obtain more information about it and get back to them.
Great, thank you. So there's a question that was submitted, and I'm going to ask this person to maybe submit some additional clarification. So the question was, outside of software requirements, any idea where we can get the new guidelines for meaningful use and where they are in effect? I'm going to assume you're talking about meaningful use for the providers, so CMS. And so again, if you want to reach out to me privately and maybe just clarify exactly what you're looking for, I can try to give you some more details on that. There's also a question just followed up, what certified edition will providers need to be using to attest for meaningful use stage 3? Again, you need to look at the CMS final rule. By 2018, you have to be using 2015 edition certified software, but there are some conditions for using 2014 edition certified software in combination with 2015, and that's in the CMS final rule. So if you want to email me, I can direct you to that section of the document. Okay, so last question. Kevin, secure messaging in the 2014 edition was for ambulatory only. Is this now required for inpatient as well?
That's a great question. I'll have to double check on that. I'm not sure off the top of my head.
Okay.
Give me 1 second here.
Yeah, so I'll answer. Go ahead.
I was going to say it's unchanged, so I believe it'll still be ambulatory only.
Okay, thank you. And so if Kevin finds something different about that, we'll get back to you and let you know. The second part of your question was none of the criteria are optional. There's 60 criteria now. Do we have to certify all of them? The answer is no. There are some baseline requirements for every product getting certified in the 2015 edition program, just like we saw in 2014. So some of those would be like quality management system, attestation. If you're doing any of the user-centered design, so usability testing criteria, you would have to do criteria in G3, but there's no requirement that you test to all 60 criteria at all. And I'm going to go through just a couple more questions because we started just a few minutes late, and I think this next question is important. So someone has said, a few months ago I heard the 2015 edition was entirely optional, but now you're saying it's not. And so it's important to remember that ONC released 2 2015 edition NPRMs, notice of proposed rulemaking. One became the 2014 edition released 2 final rules, and then they released another NPRM for 2015 edition this year back in March. That is the one that is now finalized. It is not voluntary. So the 2015 edition that became 2014 edition release 2 is the voluntary one. The true 2015 edition, the name that's 2015 edition now, is the one that's required. All right, and that looks like that's about all the time we have left for questions. If you have any other questions, feel free to reach out to us via email. And then we'll, of course, be sending the link out to the recording as well as the presentation itself. Thank you so much.